Hello, my name's Shri Pathmakanthan. I'm a consultant gastroenterologist, and welcome to 10 Images and 10 Slides. I've cornered my consultant radiology colleague, Dr. Forde, and together we're going to take you through some interesting CT images which might provide some valuable teaching tips when it comes to stuff below the diaphragm. I hope you enjoy it. Thanks for giving us your time to talk about some of these images, okay? I think this is a CT column. And I think there's trouble.
So it's a CT abdomen,
Okay.
and we are seeing it in a coronal view.
So it's coronal.
Yes,
Okay.
so the left side of the patient is here,
Yeah.
the right here, and we're
Okay.
looking straight at the patient. And left kidney here, right kidney here, liver, spleen.
And those two things are the psoas muscles, are they?
The psoas muscles down here
Yeah.
with the spinal column in the middle.
Which is a little bit curved.
A little bit of a scoliosis in this particular patient.
Okay.
But that's not the abnormality.
Okay.
The abnormality is actually here. And this long structure in the left abdomen is colon.
And why is it abnormal?
It's abnormal because if I were to pick a little bit of more normal looking bowel here, it's sort of thin walled. You can see straight away that it looks thickened and edematous,
Yeah.
inflamed looking.
And to a gastroenterologist, that will start to ring alarm bells because I'll start to go, is there inappropriate excessive inflammation here?
Absolutely. So radiologically, this looks like a colitis.
Okay.
And I'd be recommending as a radiologist that this patient have an urgent colonoscopy to figure out why. So, from a radiological point of view, we might be able to sort of guide the clinicians to what type of colitis it might be, depending on the pattern of spread. So in this particular image, we can only see left-sided colitis, and there's perhaps a bit of sigmoid colon which has been caught in the view that it's inflamed as well. We'd have to see the whole series, but it looks like a left-sided colitis
And continuous
and
colon.
perhaps continuous.
Yeah.
And that to a
Is this the optimal image, like coronal? Or do you sometimes get that other way where you're looking at the patient with the feet?
So axial is the other way.
Yeah.
It really depends on what you're
Looking for. Yeah.
I mean, I think, just to see it instinctively, this is what people sort of might, you can imagine the patient lying down on a couch and this is what you're seeing, with their head up this end, feet up this end.
Okay.
And I think it's sort of a very intuitive way of looking at a scan.
Okay.
And
Great.
that's helpful.
Anything else to comment on this? I don't think so. The color is black. So does that mean black in a CT might indicate
Yeah, black on a CT scan. It depends what windows you use. You start getting technical, but in a CT scan, you often window for different settings. So if we're looking at soft tissue, we window for an abdominal setting.
Okay.
If we're looking at the lung, we window for a lung setting. And if we're looking at bone, we would window for a different setting.
Now, your expert eyes have honed in straight on the pathology, but will you point out a few surrounding structures for us?
Okay, so liver, right upper quadrant. You've got the right hip, left hip. We've got catching a little bit of the aorta, and there's a little bit of
calcium.
calcification there.
Yeah. My psoas is not here. No.
Not well. So as
Okay.
we're catching a little
Okay.
bit of psoas there, the scan will go in and out and plane.
Okay. So we're looking at dilated bowel.
So we're looking at dilated bowel, but this is not pathological. There is
Okay.
pathology on this, but it's dilated bowel, and it's dilated intentionally because this is a CT colon, where we have given the patient bowel prep, put a tube in their bottom, and insufflated air with the intention of plumping up the bowel, the colon, to get good views of any pathology that might lie within it. And straight away we can see pathology, because if you haven't noticed already,
Okay.
you can see that there's a large Craggy's filling defect in the right colon here. And this is entirely in keeping with a colon cancer.
And do you think that craggy large lesion is causing this proximal, or is that...
No, this is so it isn't called the distal distension all down here is all intentional. It's us
To
putting-
open it up.
to open up the bowel.
Hence unveiling the pathology.
Correct. To
Yeah.
actually see the pathology. I mean, this one is pathology very obvious, but we could potentially be seeing little polyps. We can detect polyps.
Sometimes when you do this.
We can reliably detect polyps over a centimetre, and very reliably detect polyps down to 5 millimetres with this sort of technique.
Just to finish, so that is the right colon.
Correct.
As we look at it. And this is the small bowel or the left colon?
No, this is the left colon.
Left colon, gotcha.
Left colon.
Lovely.
Colon. There's a little bit of oral contrast, which we actually use to prep the colon in the small bowel.
And what are those dots you're
just the dots
contrast.
this is oral contrast within small bowel loops.
Okay, so that's small bowel.
Yeah.
Okay, so we can actually differentiate that. So that's a really marvelous example of using a CT scan to make a diagnosis, Colin.
Correct.
You've got it. You've nailed it.
Yeah, we've nailed it. I mean, there's it's the first step anyway. Clearly, this needs further investigation and urgent colonoscopy to get some tissue to prove it's a cancer. And but the nice thing about this, it does a secondary thing, which is to stage it, to see how advanced it is. Are there liver mets?
Yeah. Okay, and is there spread around the area as well?
Correct. And that's really important to know how far the tumor has advanced to.
And for students, they should
inform management.
I guess read about the Duke's classification for colorectal cancer.
Yeah,
thank you, Colin. Okay, Colin, we're back to talk about another axial CT image in one of my patients in the past who presented with gross weight loss and some rather pale, bulky, offensive diarrhea. And as usual, part of our diagnostic workup included a CT scan. And as usual, you come up with the goods. So point me out with a few structures and take me through this, Colin.
Okay, so this is an axial slice from a CT scan. So this is, imagine that the patient is like a sliced pan of bread, and we are cutting through the patient.
And it's feet.
So it is confusing, but this is the left side of the patient and this is the right side of the patient.
Okay.
So you have to imagine that the patient is on their back and you're actually looking up their bottom, essentially.
Okay.
So that you're looking up from their bottom end, and the left side is on this is as indicated, and the right is the other way. So we're seeing a view of a slice of the upper abdomen, and this is the liver,
the largest
structure here.
Yeah.
We can catch a little bit of the portal vein.
Nice one.
So the left and the right hepatic portal vein.
Yeah.
We're not sort of low enough just to see the main portal vein, but it would be on a few slices below that. We can see the stomach here, which is filled with some water. Left kidney, spleen, just the tail end of the spleen
as you look at it,
you look in. And actually, here's a little bit of colon.
Okay.
So the only structure I haven't pointed out is
the important bit.
Important one, because unlike the other structures, you can see straight away there are bright white dots in it. And if you haven't guessed so far, this is the pancreas. So the pancreas, we're not seeing the full pancreas on this one slice. We'd need to scroll down and see a few more pictures, but we're seeing the distal body and tail of pancreas in this image, and there are it is obviously abnormal, and these bright white dots correspond to calcification, and we know straight away that that's chronic pancreatitis.
I'm going to use the word pathognomonic.
It is pathognomonic.
And when you marry with what you're describing with the symptoms, and it really does make sense for chronic pancreatitis.
Absolutely. It would need to be correlated with the other features you just mentioned, but this is or chronic pancreatitis.
Fantastic, thank you. So we're on, and this is not a CT scan column,
No.
But this is so important when I go on a ward round and find somebody with perhaps inflammatory bowel disease or terrible C. diff colitis, and I'm concerned because their abdomen is distended, they have a temperature, their white cell count is going up, and I get a plain film of the abdomen, and you give me lots of information. Could you take me through this plain film?
So abdominal X-rays are useful for certain indications, and the situation you describe in a person with known colitis is actually quite a good reason to do an abdominal X-ray, because one of your questions will be, if that patient is unwell, do they have bad inflammation?
Yeah.
So what we're seeing with this, so we haven't quite included the full pelvis on this particular image.
Okay.
But what we can see, what's really obvious, is the colon here.
Can I say the black bits are air?
Black bits are air,
Yeah.
and these bits here, these are small bowel loops here that are sort of bunched together.
Big thing in med school, still for me I struggle with, but I'm better at now, is differentiating between large and small bowel.
Difficult, but one of the things, there's a few things you can consider. The first thing is size, really. So obviously small will be smaller than large. Now, we're going to go on, this is pathologically large. This is not normal.
What makes it pathologically large?
Over 6-7 centimeters is pathologically
And the measurement is across, is it?
So that we would measure here. So pathological enlargement. The second thing is that small bowel loops, I'm going to just do a little diagram here, tend to have what are called valvulae conniventes that completely cross the
Remember that term,
small
guys.
bowel.
Valvulae conniventes. Yeah. And let me preempt you and say in the colon, it's something to do with haustra.
Yeah. Whereas, yes, exactly. So we're in a colon, you're going to tend to see haustra, haustral folds like so.
Okay. So this is pathology. This is serious.
This is
To my mind, I've given you clinical context, and it could be what I would call a toxic megacolon.
Correct. Yeah.
But if this gentleman or gentlewoman had a obstructing lesion further down, this could be colonic dilatation.
It could. So the bowel is bigger. So you're right. So it's either bigger because there's a downstream pathological obstruction that's causing the bowel behind it to swell up, or in this case, because we know the history, there's an intrinsic abnormality in the colon that is causing the bowel to relax and pathologically
expand.
So obviously the real concern here is, has this patient perforated? Because that would be an indication for urgent surgery.
Okay, I'm being cheeky, but on this plain film, will you be able to call a perforation?
So perforation, the real key thing here is that perforations are much better seen on erect chest X-rays.
Okay,
you really need a large perforation to be evident on a abdominal
We'll show
X-ray.
them in our future tutorials. We'll show them one. But erect chest X, air under the diaphragm. Go and read about it.
One quite nice little point, because we were talking about haustra, is that's a haustral fold there, and believe it or not, that looks a little thick and edematous.
I wouldn't have picked that up. Okay.
This is a little bit of sort of sigmoid colon, just we're catching in the corner there.
Okay. Colin, thank you. Okay, so earlier we talked about what an inflamed colon might look like. Things can get worse, Colin, much worse. And I think a similar scenario is playing out here with perhaps a complication.
There is. We actually have two images here. We have an axial image here and a coronal image here.
Okay.
And this sort of leads on from the previous abdominal X-ray case where there was bad dilatation. So straight away we can just maybe point out some structures quickly. So we have liver in the right upper quadrant. We're catching a little bit of stomach here, a little bit of the spleen. Obviously some vertebrae in the midline. These are the iliac vessels here.
Oh, wow.
And
is that
this
bladder?
is the urinary bladder.
Okay.
So that's not the pathology. The pathology, though, is here. It is here in the colon.
Okay.
And here in the...
Now, black is air, and I don't see much blackness in there, but the colon's filled.
The colon is grossly abnormal here.
Okay.
Listen, here's a little small bowel loop.
Okay.
And it is really thin-walled, as you can see here.
Yeah.
Whereas the colon is the wall is massively thickened compared to a relatively normal colon wall there.
Swollen colon.
Swollen, edematous, inflamed.
Yeah.
Really massively slow. And in fact, we can know there's inflammation because there's little areas of fluid just here and this big one here in the pelvis.
Whoa, okay.
Which this is outside bowel.
So what you've delineated there are like sumps of fluid, like.
So it's sumps of fluid. It's, in the presence of really gross inflammation.
This is not good.
Not good.
Okay.
But we have an axial image from the same patient, which again demonstrates the really, remember, this is the left, this is the right.
Yeah.
A gross abnormality in the
That's
colon
all
here,
large bowel.
All large bowel.
Okay.
So we're getting a catention, a little bit of right colon, most of transverse colon, and then left colon here. So the one thing that we all worry about is this abnormality here.
That's black, that's air. That is not in the colon column.
Absolutely.
So that's bad.
That's bad.
That shouldn't be there. That's a perforation.
Yeah.
Okay.
So that's an indication that this patient needs really urgent.
So we're looking at a
treatment.
surgical abdomen.
We're looking at a surgical abdomen
Okay.
that needs treating.
Okay, fantastic. So here's another axial view of one of my patients. And she had inflammatory bowel disease, more specifically Crohn's disease of the small bowel. And that part of that bowel was resected successfully. And what happens is when you join up, you have a neo-terminal ileum. And she's back. She's back with a lot of distension, abdominal discomfort, and a change in bowel habit. And that's put her off her food, and she's lost a lot of weight. Column, obviously, in Crohn's disease is kind of incurable. And we are most concerned about looking out for recurrence, re-emergence of this disease. And you've helped us with this. How have you helped us?
So we've done a scan. So for Crohn's disease, you can do a CT scan or an MRI scan to firstly check if Crohn's has come back, and secondly to see if there's any complications if the Crohn's has come back, such as obstruction or perforation or local collections. So that's the principal role of imaging. As you just mentioned, Crohn's is a chronic disease that doesn't go away, and our management is centered around trying to keep symptoms at bay and as low as possible. So in this particular lady, we've done a CT scan, and it's an axial scan. Again, the left and the right side of the patient, we are looking up from their bottom end, and spine at the back.
Yeah.
And most of these are just ordinary
Small bowel
loops.
Yeah.
And they've been filled. For this particular type of scan, we have asked the patient to drink loads of water, and it's filled up the small bowel.
Okay.
And what it has done in this particular image is highlight an abnormality. The abnormality is here in the right colon. So we know that this patient has had a resection, because
Why?
we can
'Cause
see
are those the clips?
white suture material.
Suture material.
Okay. And we can see that the little bit of bowel coming into the colon here.
So that's the suture material delineates the anastomosis.
Absolutely.
Yeah. And it looks like that. Comparing it with the rest of the small bowel, that area doesn't looks. Okay, why is it abnormal? It looks swollen and.
Well, why it's abnormal is the wall.
Okay.
The key is the wall. Look at this wall. It is thickened.
Okay.
So it should. It's like that is significantly thickened. When you compare it to somewhere like the normal small bowel, there it is significantly thickened.
Okay.
And that's what draws our eye. And
thickened. I'm gonna say narrowed as well.
Well, in this particular case, we're actually not seeing narrow.
Okay.
We can see a lumen down the middle.
Okay.
So it actually isn't properly narrowed on this particular image. But what we can see is that there is some mucosal enhancement. So that's one of the radiological things we look out for to see, is there active disease.
So is that really pointing towards a re-emergence of Crohn's in that area?
Absolutely. That this is
great.
This is significant active disease, and the patient would need to be referred back to their gastroenterologist to consider what to do next.
Yeah, I'm lining up the drugs. Okay, Colin, great, thank you. Okay, interesting scan. Okay, axial, am I right? I'm getting good at this now, Colin. Axial, and lots of structures with different shades, and they have relevance as you're going to take me through them.
Okay, maybe a little bit of quick normal anatomy. It's a
Yes.
single slice of this axial scan with the patient's left and right as shown. You've got liver. We got a little bit of right kidney peeping in.
Okay.
This is probably a cyst at the lower pole of the left kidney that were partially included.
Okay.
We got a bit of colon here.
And black means air.
A little bit of colon here because you can see the poo, see that mottled sort of look to the just the poo there. There's a mottled appearance there.
And then there's the elephant in the room.
Yeah, this is abnormal.
Okay. That's the largest vessel in the body.
Aorta.
Yeah.
And it's not a normal aorta. That is larger than it should be.
Okay.
We've got the inferior vena cava here. But the aorta should be maybe slightly bigger, 2.5 centimeters, 3 centimeters is normal, but it's much enlarged. It's probably 6 centimeters.
So what's the relevant measurement? Just that
so
we
the
all talk about.
Oh, so the outer to the outer diameter.
Okay.
So the outer to outer diameter is
Now, I know blood is not white, but that thing's full of white.
It is, and we in this particular scan, it has been done in what's called an arterial phase.
Okay.
Because when you inject IV contrast, it's injected as a bolus, perhaps 80-100 milliliters, and it's injected at the beginning, and it's started at about 4 mils a second, and it courses from your antecubical fossa back to your heart, and then out to the arterial system.
Okay.
So this particular CT scan has been caught probably about 20 or 30 seconds after that initial injection of contrast.
Hence the white stuff in
Hence
it.
it's bright white.
Yes.
So,
But the ring of white stuff is different, is it? Or is it still contrast?
no, so in this particular case there's an aneurysm here.
Okay.
And we have the white contrast of the lumen where the blood is flowing through. We've got the outer wall of the aorta, which is calcified, very heavily calcified and pathological. And in fact, this is all thrombus between the true outer wall and the inner lumen. So this is a heavily an aortic aneurysm with thrombus.
Fantastic. Colin, thank you. So, axial view. Even I know this is grossly abnormal.
This is grossly abnormal.
Point me out some stuff.
Okay, there's it is so grossly abnormal because there is just there isn't
The liver's not right.
The liver is not right, and in fact there's only small amounts of relatively normal.
What is that you're circling, Colin?
So I'm trying to show you the white. This white shape is the normal liver, and the rest of the liver, which is
That's all that's left of
that's all that's completely normal looking.
And all the rest
is abnormal. It is fluid attenuation. It is cystic. So we know that this is basically all
fluid-filled cavities that are delineated and circumscribed.
Absolutely. And actually, if we look at the scan a little bit more, we get a little more clue about what might be going on, because the kidneys are also abnormal.
Oh, yes, yeah.
So rather than the usual sort of white, like of enhancement of the renal cortex, in fact, in this we can see it's been replaced by innumerable cysts.
What is that in front of the spine? Just as
an is a aorta with some calcific blobs in its wall.
So this we've served this up just to illustrate that cysts. You'll be able to blot the kidneys in this case, and you'll be able to feel a large liver, and the CT scan is diagnostic.
Absolutely. So it's diagnostic of polycystic kidney disease.
Okay, great. Thanks. So here's an interesting plain film, which we kind of also incorporated because it's not uncommon as a surgical presentation.
Absolutely. And a lot of elderly patients will have this problem as a general rule. And one of the first line investigations, if a patient with abdominal distension comes into the A&E, is to get an abdominal X-ray.
Yeah.
So here we've got an abdominal X-ray. Although we are not quite seeing the pelvis here, we're just seeing the sort of wings of the iliac wings. But we can definitely see that there is an abnormality here. And I think it's pretty obvious to see that there is a big dilatation
and
big
colon.
gas-filled loop of colon.
And colon is either full of air or poo. Can
Yeah.
you point out the air and the poo to me?
Well, poo is generally got this sort of mottled
Yeah.
look.
Yeah.
It's sort of got this sort of mottled look. That
Okay.
These are probably good areas. They're sort of patchy. Whereas something like air
It's
is
just black.
Is black.
Yeah.
Yeah.
And we can see, if you trace, you can see that the large bowel is just grossly distended.
It
here,
is
isn't it?
grossly distended. There is, and in fact, it has something extra though. It's something that we do look out for.
What's
And I
that?
did try and mention that we see this in elderly patients a lot, but we get this sort of hilum or up the middle of the structure, and this is very typical of sigmoid volvulus.
Okay, and what is that the structure
That's the structure.
Okay.
So in the pelvis, it's twisted around. The sigmoid colon has its own mesentery.
Yeah.
And it's not fixed at the back of the abdomen like the ascending colon and the descending colon.
Yeah.
It's actually got its own mesentery, so that
That's from embryology and stuff,
That's
isn't it?
embryology.
Yeah.
The sigmoid colon floats in the abdomen, and what can happen is that it can
because it's
spin
prone,
around
right?
to
If it's not
itself.
fixed, it's prone to twisting around.
Absolutely.
Can I just show off and use the radiological term, the coffee bean sign?
coffee bean sign.
Yeah. So
that
is there a
the-
coffee bean here or no?
Yeah, I think so. So this is the hilum, is the coffee bean. Yeah. So
Okay.
I think we would sort of, if we
Large coffee
if we sort of had the rest of the abdomen, the pelvis included, it would
Yeah.
sort of look like so.
Fantastic.
Yeah.
Thank you, Colin. So, Colin, we're going to finish with something kind of out there, okay? This is not in the abdomen, but this is really abnormal, and bad things happen to this patient.
Very grossly abnormal picture. Again, we've got an axial slice, but this time we're looking at the thorax. And again, we've got the patient's left, the patient's
Why
right.
is this the thorax?
Thorax, because we are seeing
Black as air.
Black as air. So
Lungs.
Lungs.
Pair of lungs.
Pair of lungs. Okay. We are actually also seeing the ascending aorta
Okay.
and the descending
Okay.
aorta.
So we're in the thorax then, yeah. We'll see that.
We can see left breast, right breast.
Okay.
Okay.
Now, does that look normal? Left breast
No.
and right breast?
So I think anyone can see that there is air. There is tons of air.
Not right.
That is grossly abnormal, and it indicates a severe soft tissue infection of both breasts.
That's unusual, but can be very severe and very dangerous for the patient.
Yeah. So it indicates a severe tissue infection and would be typical of
Necrotizing, fasciitis, things like that.
Yeah.
Okay. That's the kind of anomaly I wanted to finish with, just to keep our audience thinking and looking forward to our next series. Colin, thank you so much. So I hope you enjoyed that. That was 10 images and 10 slides. And we will hopefully be having a lot more material coming in the future for more education and informative purposes. Thank you very much. Bye-bye.